Welcome to the Health Overview and Scrutiny Committee of Woking Borough Council. My name's Alison Swaddle. I'm the councillor who will be chairing this committee tonight, and I'm welcoming here with us in the chamber councillors Adrian Mather, Jackie Rance, Sam Akhtar, Michael Thurmager, Tahir Mar, Barry Patman and Rachel Bishop-Firth. And with us on Teams we have councillor Jenny Cheng. And we'll also be welcoming various officers from the council, from the Royal Berkshire Hospital, and we welcome you all this evening. Callum, do we have any apologies?
Yes, Chairman, just Councillor Calderan.
Thank you. Members, do you have any declarations of interest?
No.
Okay. Do we have any public questions?
None received, Chairman.
Thank you. Any member questions?
Again, none received.
Right. Moving to the first item, number 54, the Berkshire West Winter Communications Plan, which in the agenda is from page 5 to page 18. Okay.
Oh, hello, that's me. I'm Niall. I'm the Campaigns and Marketing Manager here at Royal Berkshire NHS Foundation Trust and also for Berkshire West CCG. So I'm going to share my screen if that's okay with everyone.
Okay, thank you. If you're not speaking, 18. Would you like to put your cameras off? Thank you. Okay.
Oh, great. Can everyone see that okay?
Yes, we can. Thank you.
Fantastic. So, yeah, essentially, so you may have seen an earlier version of this presentation, which was just what we were looking to do, essentially. So this is more looking back in terms of what we actually delivered in terms of the campaign. So really, it's a very kind of brief presentation, but first and foremost, we were when we were developing the plan, we kind of engaged with a huge variety of groups, essentially. So we engaged with the trust itself, so speaking internally to different departments, so the emergency department, senior stakeholders, nurses, doctors, basically finding out what's the situation on the ground and how can we best serve them. We spoke with Berkshire Healthcare NHS Foundation Trust, particularly around the work we did in the campaign around mental health around the Christmas period, and they were really valuable in terms of developing the content for that. We worked with Self-Central Ambulance Service, particularly around the proper use of 111 and the use of emergency services. We worked with all the different Healthwatch organisations, so Reading, Wokingham and West Berkshire, and that was kind of develop content, see the best ways of delivering the campaign, making sure we can reach the most hard to reach people in the community. We also spoke to Pharmacy Thames Valley, because we know pharmacies were particularly under a lot of pressure and actually a kind of a area with not.
Sorry, excuse me. Could I ask you to just slow down a bit?
Sure, sorry. That's no problem at all. Sorry, I do speak quite fast. So.
Yeah, it's okay.
No worries at all. No. So we also spoke with Pharmacy Thames Valley, and that's kind of developed work around making sure people get their prescriptions properly over Christmas and the winter period, making sure people go to the pharmacies at the right places at the right time and where they can kind of help out some pressure in that area. And then finally, we also spoke to the local councils. So we worked quite closely with the local communications teams to make sure we could properly distribute the messages, but also to kind of have input so we can make sure that at each locality we delivered something that was really accurate and true to the local area. So as you may have seen, our kind of plan we developed was focused around really 3 key messages, which we thought would tackle 3 different areas within the problems we were looking at this winter. So the first one was around being prepared, and this really is trying to avoid people needing to access healthcare services in the first place. So really that's about reducing pressures and encouraging people to take steps themselves. So really the messaging around here focused on what should people have stocked up at home? How can they have conversations about mental health services so over the Christmas period they don't get too isolated? How do you look after vulnerable, neighbours, friends and family might be concerned about? So really the idea of those ones is how can we reduce pressure coming into the system unnecessarily? The second one was about choosing the right service. So if you do need to contact or you do need to reach out with a health system, making sure you're going to the right place. So we know that a lot of time people might be going to 111 when actually they should be going to emergency services or vice versa. We really want to kind of focus though around in this area around encourage people to make proper use of 111, understanding what the difference is between urgent and emergency from a public perspective. And so this was really about behaviour change. And then the last area of this was we called See Your GP Differently. So this was about decreasing some public dissatisfaction around changes in primary care, particularly by highlighting the different roles that exist, so that when you contact your GP, you might not be seen by a doctor, you might be seen by a nurse, a physician associate, a social prescriber, and really explain to people why they've been triaged to a different service, but also the benefits of alternative face-to-face appointments. So still that face-to-face appointments are there and are valuable and should be used when necessary, but also why they may have been given a telephone appointment as an alternative, essentially. So what do we actually deliver in terms of the campaign? So we think, well, from my side, I think we did delivered quite a lot, essentially. So in terms of what we actually delivered, first and foremost, we built a website that had its own section, and this was contained within the current trust website, containing a huge amount of resources. So how you can refer yourself to talking therapies, what is the stuff you should have stocked up in your medicine cabinet at home, where is a minor injuries unit, what are the different roles within a GP surgery? So really a huge amount of resources, which is where we were directing everyone to as our kind of main point of contact. We also run a bus campaign, which is the first time we've done it as a trust, and this was run with Reading buses on 30 buses that really we prioritised going in all areas. So went out to Wokingham, West Berkshire, as well as Reading itself. And this was particularly effective, we think, at trying to reach people we might not be able to get through other means. We also produced a variety of printing materials, so posters, which were just banners, which are distributed across sites, GP practices within the trust itself, and our various sites across the areas, as well as leaflets we distributed through our kind of healthcare services. We produced a huge amount of digital graphics. So that one there, for example, is one of our ones encourage people to stock up, particularly on inhalers, because that was flagged as a big area of concern before Christmas. So we produced over 30 different graphics. Those are used for social media, email signatures, website banners, put on digital screens in GP practices and other areas, and a whole variety of other locations. We produced and published 15 different videos. So that's including what's stuck up at home, which you can see there, how to start conversations around mental health, what's the difference between emergency and urgent care, as well as one-on-one videos about the different roles in primary care. Social media was a really big thing for us as a campaign, just because it's a really measurable area. We put out content on Facebook, Twitter, Instagram, LinkedIn, Nextdoor and TikTok. Nextdoor is a platform we haven't used before, and we kind of started doing as this campaign, and we found it's been really useful in reaching out to the community. We also did a paid campaign, which so we basically paid to put out certain messages into the area. So the graphic you can see on the left there, which is the pharmacies one, in the lead up to Christmas, before them closing, we paid for every parent in Reading and Wokingham and West Berkshire to see that on Facebook, Twitter or Instagram, just to make sure that's a real reminder. And that's an area we think the paid campaign was really successful. We also did a winter challenge thing, which you can see in the top right there, which is created the kind of choose your own adventure story. If you visit that handle, which is Berkshire Winter, you can have a look at that. But that was just a little kind of fun thing we did a little bit differently. Events, we ran a few kind of public facing events. A big one we did was a live Q&A, which was particularly targeted at Wokingham parents, because we worked closely with Intelligent Health, who I believe have delivering Beat the Street in Wokingham recently. So we did a Q&A aimed at parents with one of our paediatricians and Dr. William Bird from Intelligent Health. And that was aimed at answering kind of common questions parents would have about managing common illnesses. And the feedback we had was really positive, that parents were able to answer questions that they weren't able to get to their GP. And so we think that has definitely had an impact, at least during the week it was delivered, towards services. We also got press and media coverage. I have to admit we didn't secure as much as I'd hoped. We only secured maybe a handful of coverage that we could definitely say was tied to this campaign. But that was in BBC Radio Berkshire, Wokingham Today, Reading Chronicle, Berkshire Live. And we also delivered partner comms. So that was working closely with Wokingham Council and other councils, essentially, local trusts with the CCG, with the PCNs. And that was used to kind of cascade messages across the entire area. So what are the kind of results of the campaign? We're still collating a lot of results, so I can only give you some of the top level stuff. We're running actually some focus groups next week for specific people to actually get delve into detail, but I've got some top level results which I can share here. So for social media, which is really easily measurable, we really had a positive impact. So Facebook, over the course of the campaign, we had 169,000 impressions which were directly tied to the campaign. Similarly, quite good numbers on Twitter and Nextdoor. Instagram was a bit poorly performing, but if you looked at, say, the Trust Instagram account, we're not quite there in terms of our amount of followers yet. So we think that was just how limited we are by our platform, essentially. And this isn't taking into account all the partner comms. So this isn't Wokingham Council tweeting out or sharing messages as well. We also did a survey recently, which we were collecting kind of qualitative feedback, which was basically ask people. We sent people imagery of the campaign. So this is, the big posters you may have seen, which is doctors and nurses in winter gear, just to kind of see how familiar people were with it. So we did a survey and about 35% of people said they definitely recognise the imagery, with about 7% saying they think they did but weren't sure. Even though we'd say most people surveyed didn't seem to do that, I still think that's a really positive thing for a general public campaign. Around 40% could have possibly seen that imagery. We also asked where they saw the imagery, essentially, and unsurprisingly, most people said they saw it from social media. We do have to admit that some of the data came through was through people through social media, so it will be a bit biased that way. But you also see that printed materials, the bus campaign and the website were also really highly effective tools. So we're definitely going to be using this to look at how we're going to deliver campaigns in the future and see where's most effective. This is the last slide for me, but I guess the last thing I'll just say before kind of open up to any questions from anyone is this was our first kind of campaign I've been in charge of in terms of winter. Looking at terms of what went well and what didn't go well, I think what we want to do ahead looking for next year's campaign is the areas we think were really successful were the areas which were areas of very small focus. So encouraging people to stock up on their medicines or encouraging people to sort out their prescriptions for Christmas. Those are the ones which we know we had a really strong impact. And we think those are areas where you just have very quick wins and very direct actions people can take. The behaviour around, when you should go to ED and when you should go to a minor injuries unit and when you should just call 111, it's very hard for us to say the kind of impact that had. And I wouldn't be surprised if it wasn't that strong an impact. And so I think we want to approach that as a more year-long campaign and winter becoming a bit more of a focus on what are the kind of quick key actions people need to take for this period and actually building the longer behaviour change all year round, so people aren't hearing these messages just when they get to winter, but actually looking ahead to stuff that they can kind of deliver and do all year round, essentially. So that's it in terms of the presentation from me, but I'm very happy to take any questions. I'll turn on my camera now.
Thank you very much for that, Niall. So you spoke about what you felt were the successes. How are you able to measure those? So
some of it we're still collecting the data. So one of our main ones is looking at the actual engagement we had. So we know, for example, with the repeating prescriptions, we had about, of those 169,000, we know about 60 to 70,000 of those impressions were directly tied to that. We are working with the pharmacies team to actually go, in that week, did you see a big bump? So we're looking to kind of collect that into more practical data. So I think those are the areas where I think we're more likely to see successes, just because we can then tie that into actual concrete outcomes. With, say, did this have an impact on ED pressures? We saw, very sustained periods of pressure, and it's very hard to say, would the campaign, if we didn't deliver the campaign, would it have been more or less successful? And so that's why I think, again, looking forward to the future, we might try and change a little bit, because it's very hard for us to come here and say, well, we know this is really successful in that area, because we can't demonstrate it beyond, we can guarantee this is how many people saw the advert, essentially.
Yes. Members, who would like to ask questions? Okay, let me make a note. I've got Sam, Rachel, Michael and Tahir. Okay, Sam.
Thank you, Chair. Great presentation. I thought it was really interesting and very detailed, and really nice to see us as someone who loves social media. It's nice to see the breakdown, what the different channels are using. One of the questions I had is, sort of linked to, looking at, where the results could be. Could some of these social media channels and like the TikToks and Instagrams and on top of the Facebook, the way you're, looking at getting comms out via these channels, could this be a way of letting residents know, as we get out of COVID and we get into more sort of BAU, things like your annual flu jab or other various sort of non-COVID related jabs, could these sort of be something that you could use these channels to promote that? And then that could be a way of analysing, okay, you could quite easily then measure, oh, we've had an increased engagement of people getting their winter flu jab. It'd be interesting to hear your thoughts on that.
Yes, so this is the first so I'm quite new into the role of campaigns and marketing manager, and I think this was our first big one. And so absolutely, I think I kind of saw the winter campaign as our first opportunity to kind of deliver a whole bunch of things and see what works, what doesn't, essentially. And I think social media was really effective. So I think absolutely, I think we're only starting to make the best use in terms of our social media, and there are some channels, as you mentioned, kind of TikTok, Instagram, I still don't think we fully scratched the surface of what we're able to kind of deliver there. So I think absolutely these are really good channels in terms of think of creative and interesting ways we can kind of get our messaging around flu vaccines, referring yourself, monitor yourself for kind of key types of cancer. So we've got a campaign hopefully coming out in next few months. We'll be looking at kind of cancer referrals, and we'll definitely be taking a lot of the learnings from winter and using our social media there to kind of deliver that. So absolutely agree that would be perfect for that.
Thanks, Darth.
Okay. Rachel.
Hiya, thanks very much for that presentation. It's really good to hear about your successes. With some of the areas where you felt that maybe you weren't quite so successful, what steps are you going to be taking in the future to tackle those areas? So, for example, to point people towards the best source of help for them?
So yeah, I think in terms of that, I think so we're running some focus groups in the next kind of coming week. So I think we're going to really try and get some, I think one thing we really want to learn is actually do more proper kind of contact with residents, essentially. So I think we're going to try and make sure they're more involved in the process, essentially. So that is checking the campaign materials much more closely in terms of what the impact is before we even go into delivery, essentially. So I think we really want to get them much more involved in the creative stage of the campaign delivery and seeing if that can improve that.
Super, thanks very much.
Michael.
Yeah, thank you, Chairman. Yeah, thank you for that, Niall. It was very interesting. I've got a comment request and a question. A comment request had to do with the same thing, in that the presentation didn't seem to bear any resemblance to what is actually in our agenda. So I was really hoping that you would obviously share via Democratic Services a copy of the presentation anyhow. I just wonder why, because it was a lot of, I think in the agenda in here, there's a lot of it was actually similar, but put in different places. So trying to follow it with what you were doing and follow it on here as well, because you try and sneaky peek a little bit ahead, it was not easy. But my question is, when you referred to the local press, local media, Woking paper and so forth, that you didn't feel as though you got as much, I think, impact as you'd hoped. Do you know why that happened and how you can sort of remedy it next time?
Definitely. So I think the always thing with the press I find is they want to know, why is this newsworthy now, essentially. So beyond just general winter pressures, what's the importance of getting people to call 111 instead of rocking up to ED? The few areas we got coverage were areas where we kind of said we've got something to announce or something big to push. So we did get some coverage around what's stuck up at winter, because that was seen clearly as a winter area. And we also, as part of this campaign, did a little work around abuse towards staff and treating them well despite these pressures. And that kind of tied into some kind of larger national stories. So I think looking again in terms of what can make it more successful, it's how do we make the areas of the campaign much more newsworthy and current to them, and also looking at the national picture and making a better advantage of, is there national stories where they're looking for a particular angle about that? So I think that's the area where we fell down a little bit more for the press, because I think sometimes they're like, what is the value of doing this now, as opposed to waiting a month from now to do the same story?
Yeah, thank you. I sort of feel that the press obviously want a good story on there. So maybe a bad headline or a good headline, I don't know what, yes, but I do appreciate that. But yeah, you also made a good point about linking in with the national NHS as well as the local one. So yeah, fair point to make. Thank you.
Tahir.
Hello, thank you for that. That was a really good presentation. I've got a few questions. I'm just trying to get my head around. I was looking at what you were saying through the initial objectives that you, or the core areas that you were talking about. Be prepared, choose the right service, and see your GP, etc., the various people. And I was trying to relate what you were saying in the different campaigns to that, and it wasn't that easy, to be honest. And I was wondering, is there a core message that you were trying to get through? So that was one thing. Secondly, which of the, you've used a lot of the social media platforms, which one is the most successful? And you didn't talk much about the geographical areas. You mentioned various elements, but were you particularly successful in one part, Reading, Wokingham, Bracknell or something, as compared to others? Did you do any of that kind of analysis? Thank you.
Yeah. So in terms of core message, I think our overall brand message was basically telling people to get ready for winter. So our overall campaign message was called "Are You Winter Ready?" I do think you raised a good point of where the campaign could have been a bit stronger. Was I think in some days we were very ambitious, and at some points maybe too ambitious. So we had our 3 key messages, and we had several things that span off that. And probably what we want to do for next winter is focus down much more and go, okay, what are 4 or 5 key points or key actions we want people to take rather than 3 broader key areas. So I do agree with you there. In terms of social media, I wouldn't say that necessarily one platform did better than the other. I always personally love Twitter, so I feel much more natural and that I can do much more there. So I naturally gravitate towards there. But I do think probably Facebook was really successful. Nextdoor, which we never had used before, was surprisingly really effective. We had high levels of engagement conversation happening there, which we thought was really good. And Nextdoor, were able to communicate to a much wider audience. So I think that was a really valuable one in terms of reaching out to different areas. I don't have too much data on specific geographical areas. I can probably get that data for some of our paid campaigns, though. I'm sorry I don't have it to hand, but I can definitely follow up and get that data for the more paid social media, because we did target specific the different localities essentially.
Could I? There are quite a few people who basically don't have mobile phones or internet access. How and I heard you say earlier on that you were also leafleting and so forth. Is that message getting to them, because they probably are the ones that really need to hear it as well?
Yes, I think some of it got. So we did do some targeting on social media for people we knew. We basically targeted their groups we knew would be particularly hard to reach. But I think you're also right that there'll be some people who aren't on the platform at all for whatever reason. The leafleting we think did work because we encouraged people to give an out as they came in contact with our services. So we know we were able to reach people who actively use our services. But I do think you're right that is an area we could build upon. I think as an area of work for the trust as a whole over the next year is we need to do a better job of just finding ways we can kind of communicate beyond social media or the digital channels essentially. So I think looking ahead to next winter, I think that's something we want to do much more. I think the way we'll probably approach that is using our staff and our stakeholders much more as communication tools. So encouraging them to reach out to their contacts, whether it's patients they come directly in contact with or people they engage with in the community. So I think that's a really good way we can kind of get into those communities much more. I think we'll also try and broaden out the partners we worked with. So we did work mostly with health organisations in different areas, but actually bringing into local community groups and different organisations like that, which we did a little bit of, but not half as much as we could done.
Thank you.
Okay, I think Nikki Lloyd has something to add at this point.
Thank you, Chair. Yes, I guess just to build on what Neil was saying, Council, like us, is an anchor institution in the midst of the communities that we all serve. And we're really keen to work with you and your contacts through the councillors and any other means you have. And I know certainly when we were in the midst of the pandemic, when I was acting Chief Exec, we were very glad of your support and being able to message through your platforms as well. So I think that's something we'd be really keen to build on, because I'd rather people got bombarded from every angle and said stop, enough already, than as you noted, there are some parts of our communities that we haven't been successful in reaching effectively. So I urge Niall to be linking up with you, if we may, Chair, and the communities that you're embedded in through the councillors and through the council communications, because those will help reach. We've also reached out through faith leaders, particularly through the vaccination campaign. We've got a microsite for engagement with the Building Berkshire Together site redevelopment, and we're also leading a big communications involvement exercise on our net zero green plan. So wherever we can reach out into communities, we're trying to do sort of a cross-boundary messaging in the hope that that word of mouth and contacts will get through. But it's a really valid point about we don't want to create even greater digital inequalities, because there are still large tranches of the communities we serve that do not have digital platforms and are not confident in that forum. We've been working with an organisation called Accessable, which is helping us make sure it's possible to navigate all of our services, for example, sight impaired or hidden disability autism. And one of the things they've fed back to us is the need to continue to plug traditional communications channels. So just as Niall said, radio and leaflets and newsprint are channels that we need to keep using.
Thank you, Nikki. Nikki's the Chief Finance Officer at the Royal Berkshire Hospital. Is that correct, Nikki?
Yeah, it's
Hospital Trust.
Royal Berkshire NHS Foundation Trust.
NHS, yes.
Yeah, I'm the CFO, but but I'm here representing the organisation with my colleagues this evening. So thank you so much for inviting us to join you.
I know Adrian's got a question.
Yeah, thanks very much, Niall. Thanks very much, Nikki. It's very encouraging to see modern platforms being used. And, you know, I saw there was lots of residents' feedback on the local groups, Facebook groups, etc. So this is very encouraging. As well as reaching out in terms of messaging, which I think Nikki made some very good points around, I would actually encourage the NHS to think not just about gathering information and feeding information out to the populace, but also think about offering, and I'm speaking as a sort of IT guy, offering a sort of single point of contact place. And what I'm thinking about here, and I will cut straight to the quick, if you like. A lot of residents complain about accessing GP surgeries and dental care. And, you know, if there were, I just checked on the Woking Medical Centre, there is an interface to the Woking Medical Centre where you can book online, reserve an appointment. But I think if there was a consistent interface across Bob, then this could be pushed out through Facebook, etc., etc. And one of the things I was also thinking about, for a lot of repetitive things, the company I work for is replacing repetitive actions with AI components. And if I look at 111, a lot of the sequential questioning is very similar to the kind of things that have been replaced by AI. So to cut a long story short, you could put something like an online 111, which would get people filtered through the 111 logic. And if that was available through Facebook and Twitter and everything else, you'd make it accessible everywhere really easily, because people are becoming more and more used to these kind of technologies. I also absolutely take the point from Tahir and several other councillors have made this point about the other generations or people who are less able to use the screens or modern technologies. But I think a lot of people are very, very happy in their own technology space and want to actively use it more. So I would encourage the NHS to think about additional usages, not just messaging.
I just say yes. I completely agree. I as someone who I would describe myself as quite a digital savvy person, sometimes I can find certain NHS web pages difficult to manage. I think it's a good thing to do regardless of it's whether someone is already quite an online and savvy person or someone who does have difficulty access services. I think making it simpler and easier to access is important as possible. We did some work last year, which you may have noticed, to completely overhaul the Royal Berkshire NHS Foundation Trust website. And a large part of that was driven by the same things you're saying there in terms of making it simpler, easier to get people to the things they want, and also trying to use the language and terms that people use. So, for example, on our website, we build it now so if you search heart on there, you'll bring up cardiology because you might not understand that term, or it'll bring up skin, it might bring up dermatology. But I think that is a big focus we have as a trust, is how can we make our digital services more accessible to people as much as possible, and how can we be more clever and catch up, because I know sometimes we can still, even if we update stuff, we could be a bit behind, and I don't think we're quite at AI point yet, at least for anything I've been involved with, but I do think trying to keep abreast of what's going on is really important.
Thank you very much.
I think Councillor Rachel Bishop-Forth wanted to come back with another question.
Yes, I've got a couple of questions actually. I was just wondering whether you try to reach out via schools, food banks and organisations such as First Days, for example, who sometimes can make contact with some of the groups which are harder to reach.
So we didn't for this campaign, but I think schools was a real area which I wish we did kind of get involved. I used to be involved actually with Intelligent Health with the Beat the Street programme, and we use schools and they're really just invaluable in terms of reaching the entire community. So I think schools is definitely an area I want to do for our future campaigns, because actually they're really useful regardless of age or background of being able to kind of get a message out there. So I think definitely we want to. The one area we did get schools involved with is when we did our live Q&A aimed at parents. We did work with schools in Wokingham to actually get that message distributed. We had several hundred people attend, which was really good for that webinar. So we think that was really effective, and I think we do want to be doing more stuff with schools moving forward. Food banks, we also didn't get any work involved, but also an area I think we would want to do more work with in the future.
That sounds brilliant. I mean, particularly the Q&A with parents, and that sounds like a great initiative. The second question that I had written down, actually, Nikki partially answered already, which is what more can we do as councillors, particularly to continue to talk to our residents about the importance of getting the COVID booster. There is a very active campaign of misinformation out there. Obviously, I don't need to tell you that, I'm sure. And sometimes we can help to move the conversation on and point people towards some more accurate information. So I'm wondering if there's anything more that we can do.
Yeah, so my previous role actually was as digital content officer, and I'll let Nikki come in a second, but so I was often have to deal with some of the frontline misinformation. I think the key thing is making sure we're all staying in conversation with each other, and we're all speaking from the same message, essentially. I find that's the most important thing, is just making sure that all organisations are joined up and communicating the same ideas as each other. So I think some of that's on us and being better at working with you to kind of push messages out, but also vice versa, using us as a resource whenever possible. And I'll let Nikki come in now if she's got anything to add.
Well, just briefly, I know Sarah's got her hand up as well. Just briefly, yes, exactly. I mean, we want to make sure all of us who are taxpayer funded that we're serving our communities in the best way we possibly can, and certainly the powerful impact of joined up messaging. So I know we've carried local authority messages in the past, and having that reciprocity between the anchor institutions, certainly University of Reading and local authorities, and also our local members of Parliament as well. So if everywhere anyone goes to look for further information, they're seeing consistent messaging, we can all help each other, I think, with helping all of the residents that we serve to be as well and fit as they can be, really. I don't know, Chair, if we might bring Sarah in. She has her hand up also.
Yes, very welcome. Sarah is the lead consultant for Obs and Gynae at the Royal Berks.
Hello, yes, it's lovely to be here. I couldn't resist making a comment about COVID vaccinations. As an obstetrician, pregnant women are a particularly vulnerable group, and there's been real challenges around mixed messaging for that particular group of women. But we've had some real successes, and the uptake is massively improved as a result of a lot of the things that we've been putting out through social media and through the conversations we've been having with women. So all the support that you can give us to help that messaging consistent, that the vaccine's definitely worth having if you're pregnant, and it's safe for pregnant mums and pregnant babies, and it really does help protect babies and keep mums safe. We just need to keep reinforcing that message. So all help most gratefully received. Thank you.
Thanks. Rachel, did you have any other questions?
No, that was it. Thank you very much.
Okay. Niall, I think the part of your report where you covered about see your GP differently, and we all know from our residents that some people found it difficult that there was a change in the way you see your GP, and that practices were doing their best. They were, offering phone consultations, video appointments, and that's something that will go forward because we can all see the advantages. Have you had feedback from all of the teams in the GP practices that they feel that your comms have been successful?
So we've had some feedback from some GP practices that was really positive. I think the ones they found really effective was more highlighting the different roles that exist. I think sometimes people can, you want to see your doctor and you won't be put off by anything but your doctor particularly. And so we did some messaging going, actually, let's put faces to names of who is a physician, what is your physician associate, what is the qualifications they have, what is the training they go through. We've had some feedback from people involved with that's been really positively received. The GP practice work is actually stuff that we're going to carry on doing. I think it's still stuff, the problem isn't, the challenges people facing aren't going away just as we're coming out of winter. And we actually do have some comms which we weren't quite able to finish. So we have video at the moment, which is a day in the life of a GP receptionist, and actually highlighting, these aren't people without any skill. This is a really skilled, valuable role, and there's a real talent that goes into that kind of role. So I think it's an area we want to kind of continue doing more workarounds, but we definitely had a lot of positive feedback around the different roles aspect of it. In terms of the seeing people at different times, I've not had any feedback yet from GPs, but we're collecting a lot of the quality feedback now, and that's definitely one thing I'm looking out for.
Okay, at the very end of the presentation within our agenda, the last deliverable is publication of waiting times online. Could you explain a bit more about that?
Yes, unfortunately, this was something which we weren't able to deliver. It was an IT project. I'm very much aware that, if someone comes to ED, if they were told it's a 3-hour wait, that they're going to be, that you'll sit down there regardless because you're already there. So it was very much trying to be, can we be more transparent about what are the waiting times if you arrived at ED, and would that discourage maybe the small amount of people who won't be using the service appropriately? So we had hoped we'd have a tool in place which we could put on the website and on our social media and other places, which would regularly update in terms of how long you'd be waiting in the emergency department. Unfortunately, it hasn't been produced in time, but it is a tool that's still, as far as I know, our IT department are working on, and we would like to bring in whenever it's next available, essentially.
A little bit double-edged, though, isn't it? That, if somebody looked online and said, oh, well, it's only 2 hours, we might as well go to A&E, when they really shouldn't, because it's not an emergency.
Definitely. I think there's a project which, following on from this campaign, I really want to look into, which is, we did have some feedback from ED, which is, if you say to the public, ED is under pressure, our A&E is under pressure, for some people that might keep them away, but for some people does that send them there because they're going, I want to go there before it gets any worse. So actually, I think there's a really interesting work which I'm keen to possibly do some work with University of Reading to actually look into the psychology of what that kind of messaging has an impact on people and how that affects behaviour. Because yes, I think there is a bit of a double-edged sword. It might reduce the peaks, but it also might raise the troughs a little bit, as you were mentioning there.
Yeah, I think it's communicating, that you will have a long wait and your pharmacist will be able to help you far quicker.
Exactly.
Because there's still a lot of work to do, isn't there, for people to view the pharmacy as sort of the first place of contact rather than going straight to their GP.
Yes, exactly.
I mean, I think we've all been very impressed by the work that you've been doing. So much of it is not simply about the winter, is that it's it's an ongoing thing that you're going to be continuing. I'm not sure I've seen any of the videos. Perhaps I'm not on the right platforms. I must say my own GP practice at Loddon Vale, they have a Facebook page where they communicate very effectively. And I think if more practices had their own direct comms like that, it would be a really positive thing, because a lot of people go on there to post praise and you know, thanks and say how good it is, which is a double boost. You know, it makes the other patients think, well, this is a good practice, and it helps the staff realise that it's not just all the angry people shouting down the phone. The silent majority are out there. So thank you very much, Niall. Members? I think we're all quite satisfied.
Thank you very much.
Thank you.
Thank you very much.
We're going to move on to the next item on the agenda, Maternity Services. And we've already met Nikki Lloyd, the Chief Finance Officer, and Sarah Phillip, the Lead Consultant, and Jill Valentine is also with us, and Jill is the Director of Midwifery.
Yes, that's right.
We haven't received anything, so do you have a presentation on screen? Yes.
I do, thank you very much.
Okay, if you'd like to take us through that, and then we'll have questions at the end.
Lovely, thank you very much indeed, and thank you for inviting us to come along and update you on some maternity matters. So we were asked to feedback on the Healthwatch report on the experiences of...
Jill?
Yes?
Could you switch to full screen, because for members looking at this right across the chamber, it's quite difficult to read.
I think Madeline's doing it, so I don't know if she's able to do that. If not, I have got it here.
I'm sure Madeline can.
On the right at the that's it.
That's it. Thank you. Is that better?
Much better, thanks.
Thank you. So yes, the first thing that we were asked to just give you some more information on was an update on the Healthwatch report, which was the experiences of perinatal mental health support in Woking Borough, which was a report following some work that was done in early 2020. We'd then like to update you on the outcomes from the Cqc inspection, which was in January 2020. Well, the report was January 2020. They actually came to visit us in December 2019. And then I'd just like to give a brief update on midwifery staffing and how we've used the Cqc domains for service improvement. So the Healthwatch report, which came out in October 2020, I don't think I need to highlight the fact that in 2020, we had the first wave of the COVID pandemic, and during that time, there were a lot of changes to maternity services in the choices that women had, and certainly the access to some support as well, which I'm sure was a feature in some of the feedback that we've had. So the report sort of broke things down into three main areas. The first was care during pregnancy. And one of the areas highlighted was that women weren't given a choice necessarily around particularly antenatal care. And sometimes they felt or reported that they felt that they were coerced into a course of action, and that this had then negatively impacted on their perinatal mental health. So care during pregnancy, we do offer a choice, and women are offered a choice of where they have their baby and where they have their antenatal care. So within the Wokingham area, women can choose between the Royal Berks Hospital or Frimley, or there are other trusts as well. Some women choose to go to Oxford, and they can also choose between midwife care or consultant-led care. There are some criteria which would mean that we would suggest women were under consultant-led care or suggest that they were under midwife care, but they do have a choice in that themselves. We also offer women a choice of place of birth, so they can choose between having their baby in hospital, in the midwifery-led unit, or a home birth. And during the first wave of the pandemic, We were still offering a home birth service and birth in hospital, but we did suspend our midwifery-led unit as a choice for women. And that was really because we needed to move all our staff onto the delivery suite to cope with what we thought at that time was going to be a significant influx of women with COVID in labour. So that was a conscious decision that we took, but very aware that that was denying women the choice of a midwifery-led unit for their birth. The other service that we have is that women can be referred to a consultant midwife. So if they are wanting to have more individualised plans for care, then the consultant midwife can help them with those, particularly if perhaps they've had a more complex pregnancy or labour in a first or previous pregnancy. And now we also do something called personalised care planning, which is something we offer to all women from their first booking appointment and all the way through their antenatal care, so that we can discuss with them and talk to them about the different choices that they have and try and individualise the care as much as is possible for them. So the next aspect is care during labour and birth experiences. And again, in the report, it said that where women perhaps didn't have the birth experience that they either wanted or were expecting, that again, this negatively impacted on their perinatal mental health. So we had recognised back in 2019, well, the end of 2018 actually, that we would like to implement something called a birth reflection service. And so we were given some funding to run a pilot for just over 12 months, which we did. And the pilot was successful. And so it has now been introduced as a standard part of our care. So this service is run by a midwife, so women can either self-refer or can be referred to that service, where they can come and talk about their experiences and how that made them feel, and go through perhaps the records to look at the care and the choices that they had, and perhaps to understand in a little bit more detail exactly what happened and why it happened to them. As part of that service, we also do a screen for PTSD. So we know that for some women, we need to make sure that from a birth trauma point of view, that needs to take priority over talking about their sort of individual care experiences. So we work really closely with the Berkshire Birth Trauma Service to ensure that appropriate referrals are made. So we know that we've had a lot of ladies who've been interested in our birth reflection service, and the feedback that we've had has been extremely positive, with women saying how it had really helped them to understand and come to terms with their births and their experiences. We know that when women do talk to our birth reflection service, there are sometimes themes that emerge. And so we have something called an intrapartum strategy group. And the themes that come up from the birth reflection service are fed back through that group. And that group then work with our Maternity Voices partnership and other service users and staff to identify where service improvements can be made and how they can be made. And as I've already mentioned, we have consultant midwives. So again, women can be referred to a consultant midwife to talk about planning for future or subsequent pregnancies. Postnatal care and infant feeding was the third area in the report. And we know that we've had quite a lot of feedback about our postnatal care, particularly hospital-based postnatal care, and it is an area that we've been focusing on to make some improvements. And again, I think this was probably the one aspect of the service where we had the most feedback during particularly the first wave, but also the second wave of the pandemic, because initially there was no visiting allowed at all. And then it was very restricted visiting. And so women weren't able to have partners with them to start with. And then partners only were able to visit on a very time restricted basis. and this did negatively impact on their experiences. So we have recognised this, and we have got various initiatives in place, service improvement plans in place that we have worked with our Maternity Voices partnership on, and they have been absolutely fantastic in helping us to prioritise where we focus our attentions. And some of the feedback that we're getting now is that the work that we have done has been gratefully received. That's not to say we don't still have more work to do. It is an ongoing process. But we do have postnatal care plans integrated into our electronic patient records, and we also have a psychological care plan as part of that. So we're very aware that we need to make sure that we look after women's psychological needs as well as their physical needs. We've introduced a Me and My Baby app, which is a resource for women they can download before they're discharged home, and it contains a lot of helpful information, including information on infant feeding. And we're working towards the UNICEF Baby Friendly Accreditation. So these are some standards around infant feeding. And we have an infant feeding lead who is working with our staff to make sure that they have the appropriate training, the appropriate assessments, so that they can support women with their choice of infant feeding. So I'm going to hand over to Sarah now to talk about the Cqc inspection.
Thanks, Jill. Sorry, there's a bit of an echo. So hi, everybody. This is my first Healthwatch meeting, and I'm delighted to have been invited to talk about this aspect of our maternity service. So we had a Cqc, an unannounced visit, as Jill said, in 2019. The report came through in 2020. I just wanted to draw your attention or to highlight some of the key points. Overall, the service was rated good, which we were really proud of. But there were some key points under the safety domain that were highlighted as requiring improvement, and we thought it would be helpful to share a little bit of more about those and some of the actions that we've put into place and where we are. You can see on the slides there the key points, but I just wanted to draw your attention to a couple of them in particular. Firstly, the top challenge we have, as I'm sure you'll be aware, is relating to midwifery staffing, and this impacts an awful lot of aspects of the service. We've done an awful lot around this, around recruitment and retention of staff, and there's an awful lot of work that has been implemented and that's still ongoing. Just thinking about recruitment, we've been working on recruitment days, attending recruitment fairs, university days, talking to our students, and then thinking about retention and what we can do to help improve retention, keep good staff with us. We've been thinking about how we can develop staff groups such as our midwifery support workers, taking a closer look at our staff surveys to understand what the challenges are that staff are facing, and thinking about the themes that come through from exit interviews. This is all really useful information to help us understand more about the challenges that staff face. And I don't know if many of you will have watched the recent TV series, This Is Going to Hurt. I think we're increasingly recognising that midwives do an extraordinarily difficult job and face really challenging circumstances. And a lot of what we're doing as a senior leadership team is trying to sort of implement slightly more compassionate ways of working and understanding the impact that working in these challenging environments can have on our staff. So we've been engaging in some a little bit of a questionnaire feedback focus group type work around psychological safety, what it is that challenges people at work, what it is that helps them feel safe. We've been thinking about how we can support people who've been through difficult experiences with mothers or babies having difficult outcomes, and when things don't go quite so well. We've been focusing on learning from excellence, so supporting and encouraging and praising staff when things go well. And all of this is really important to help our staff feel valued amidst the very challenging environment in which they work. around that, we've had some really positive feedback from our midwifery, some of our midwifery students who've been on placement with us, who've commented on, you know, positive workplace culture, good evidence of a good team working between obstetricians and midwives. So we kind of reflect that really well, and we know that investing in our students is a key part of our recruitment, because if students have a good experience with us, they're hopefully going to want to apply for jobs with us. So there's a lot going on around retention and recruitment of staff. The other point I just wanted to draw your attention to on this CQC feedback was the point about KPIs, key performance indicators, not meeting the Trust's minimum standards. So this is feedback that came from our maternity dashboard, which is where we review regularly a lot of care and treatment outcomes that we deliver to mothers and babies. This is something that we look at as a multidisciplinary team on a regular basis. We review it monthly as part of our senior strategic team and through our governance forums. And where we flag as red within our own dashboard, we have a review process where we look at what could be done, what could be, you know, go down to drill down into the individual patient level data to try and make some identify any themes that emerge. So there's a lot of work that's ongoing with that. And then the final thing I just wanted to highlight was about IT issues, which was flagged up in 2019. Shortly after this visit, we implemented our maternity electronic patient record, which meant that the multiple different IT systems that were in use at the time of the visit were integrated, and that's really helped transform a lot of what we do. And being able to capture data within the electronic patient record means that we can pull off reports to help drive service improvement. So it's not perfect by any means, but it's made massive differences and will help drive and improve, drive safety and hopefully improve performance. So I'll just hand it back over to Jill to talk a little bit more about staffing.
Thank you. I just wanted to share this chart with you, which looks a little complicated, but I'll try and explain it simply. So what we've done is we've looked at sort of monthly chunks of time, and we've looked at the number of staff that we have in post, the average number of staff that we know leave, because we do have a sort of a rolling turnover of about 10% of staff. We also have at any one time a proportion of staff who are on maternity leave, and we also have a proportion of staff who are going to be returning from maternity leave. So what we've tried to do is to factor in where we know that staff are going to be leaving or going to be going on maternity leave or coming back from maternity leave, and that's what all the different coloured blocks are on this chart, to track the projected staff in post at any one time. So as you can see, back in January, we had 165, nearly 166 whole-time equivalents in post, and we're projecting that by August that will have increased to 178. Our establishment is currently at 183, so we know that we're still going to have some vacancies, and as I've mentioned with our turnover. So as we speak right now, we know that we've got 10 whole-time equivalents who are going to be starting with us between now and April. Then we've got another 8 who are going to be starting with us by October. And we also have been doing a lot of work on international recruitment, and I have to say we have been incredibly successful with that to date. And we've got some additional funding for another 9 whole-time equivalent midwives from international recruitment, and we haven't even started that yet, but we know that those 9 people will be with us by July. So it is a gradually improving position, and as Sarah has already mentioned, with the work that we're doing on retention as well, we're hoping to bring down our turnover and reduce our vacancy rate at the same time. On a longer term plan, we have increased the number of student midwives who are coming into training with us, and we have worked with another university. So traditionally we only had one university who we provided clinical placements for, but we now have another one. And so we know that that's our main source of recruitment. And so we're really pleased that we have been able to recruit from the students and recruit more students onto the midwifery training as well, which is really good news for the future. And finally, just to say that at the end of September, our executive team attended a maternity summit. So we put on a maternity summit, and this was to support the senior clinical and operational team to work on a plan to what we call land outstanding. So what we want to do is to work towards achieving an outstanding rating in our CQC. And we know that we've got some work to do. And so we looked at each of the domains, and small teams worked on each of those to identify quality improvements. And they've been working on those in the background, and we're going to be feeding back on the 10th of March to the executive team and to other people who are supporting us in the summit. It's been a really good opportunity to bring together the senior team, so that's the operational team, the medical team and the midwifery team, with our executive colleagues to work on how we can take our service forward. So that has been much appreciated. And on a similar theme, the other thing that we've done, we've worked with our colleagues from Frimley Healthcare Foundation Trust, and we asked them to come in and do a peer review of maternity services. So they came to us on the 30th of November, and they used the CQC domain criteria and framework to talk to staff, to talk to women who've used our services, and to talk to some of the support team as well. The initial feedback that we had at the end of the day was really quite positive. It was some very positive feedback. Inevitably, there's always some actions that need to be taken, and we're waiting for the report to be presented, which I believe now is going to be next week. Thank you very much, and we're happy to take any questions.
Okay, thank you, Sarah and Jill. Sarah, we're not Healthwatch. You mentioned this is your first time with Healthwatch.
Oh.
Healthwatch is a fantastic organisation.
My fault.
Which
sorry.
goes out and talks to the people in our borough, finds out, you know, their perception, their experiences. And in fact, it was a result of one of their surveys where, well, we were quite saddened and shocked by the terrible feedback about maternity services, which is why we wanted to put this on our agenda this year. We are all elected members, we're all borough councillors here, and our job is to overview and scrutinise all of the health services for residents of Woking Borough.
Sincere apologies.
No, it's fine. Just
thank you for clarifying.
I know you're a very, very busy person, so thank you for being here. Now, that was an interesting report, but it didn't really have any actual data within it. I wondered, could you tell us, you know, the level of midwives that you expect to have on every shift and how often you actually achieve that?
Yes, so it depends very much on the warden department. So we know.
Sorry.
Gosh, sorry. Yes, thank you, because we've got some feedback. That we know that we have minimum staffing numbers for each warden department or clinical area, and we monitor that on a more than daily basis, a shift by shift basis. So it's very difficult to say overall, but on a shift by shift basis, there are some shifts where we're up to full staffing, and there are other shifts where we're not. And when we're not, we use agency midwives. We use, I think, a term we probably call bank midwives. So they're midwives who will work extra hours for us. And we also use our resources quite flexibly. So as I've already mentioned, the midwives, particularly working in the intrapartum area, so the delivery suite and the midwifery-led unit, they will move quite freely between the two areas. So where the workload is, the midwives will follow. And it's the same really across the whole service.
Okay. And I think as I was going to say, as a consultant working on the shift, you know, they're very clear escalation policies. So if you know the number of patients, if we need to move staff around, that happens regularly within the context of a shift.
Okay, so the unannounced visit by CQC was over 2 years ago now. When do you expect that they might next visit you, and how confident are you that they will assess you as good for safety?
Imminently. it's any time really. We're expecting a visit. We know that they are doing unannounced visits to other organisations, and we know maternity services are services that they're focusing on. So we're expecting it any time really, which is one of the reasons why we asked Frimley to come in and do a peer review to help us to assess and give us some confidence in some areas, but also to identify perhaps where we needed to do some further work. So that actually was a really valuable experience to do that. We have also done a sort of a self-assessment of where we are against the standards. And realistically, because our staffing is still not where we want it to be, we feel that that's still going to be an area that we're probably going to fall short of the standards. So again, we have said that we think we're going to be good overall. There are some areas where we feel that we're doing particularly well, but overall, we feel that safety we're probably going to be requires improvement again.
Okay, I can see Nikki would like to come in.
Thank you, Chair, and thank you, Jill and Sarah. I think it's important to note in terms of mindset at the organisation, we know that the CQC could turn up at any service at any day. I guess our philosophy at the Trust is that our standard is it good enough for our family, and we would hope to be ready on any day or any hour or any shift actually for any family and anyone to come in, and we would be doing our very best to give the safest service that we can. I think Jill and Sarah being extremely modest, like the rest of the population, we've had numbers of our staff who've been taken ill with COVID or have had to isolate with COVID. And you know, the teams have been working diligently throughout. In fact, we've been now having to insist with our teams that people do actually take some annual leave, because the dedication to make sure that our women and babies are safely served. And as you know, I mean, we have a 9-month lead time with pregnancy, but we never quite know which hour or day our little new arrivals are going to emerge into the world. And the way the team have juggled the staffing rotas to make sure that we've continued to provide safe services to our families and the newborns is, you know, I salute them both, because we've had significant numbers of staff impacted by COVID, as well as our patient groups, and they've just moved mountains daily and nimbly to make sure that on any day we would be ready for you or your family. And if the CQC come, that's a thing they're entitled to do, and we would do. But our planning is to make sure we are, I say, the best we can be on any day for the families that we serve. And I say, by the way, the CQC may attend, but it isn't an effort for a day. The CQC come and we would go, phew, it's all over, and then relax. That's not how our services are run. I just thought it was important to say that. I know that's implied, but we're very much in the state of being the best we can every single day and every hour of every day. And like some of the other services, which we know have what we'd call normal working hours, Obs and Gynae is open all hours, isn't it, Sarah, Jill?
It is. Thanks, Nikki. That's really good to hear. And the other thing I was just wanting to say about that is you know, part of the CQC self-assessment is a really useful guide. It's not our job to come here and paint a facade and say we're wonderful at everything. It's our job to come here and to reflect the reality of what's going on, and perhaps even be honest and open about some of the challenges that we face. And we, as Nikki said, we're by no means blasé in saying, you know, aren't we great? We are very well aware of the challenges and have worked really hard on the mitigations and the action plans, and you know, to make sure that we are fully have full oversight of the challenges that we're working with.
Okay, I can see Phil would like to add something at this point. Phil Cunnington's a deputy lead member for adult social care here at the Borough.
Thank you, Alison, and health and wellbeing. So nice to meet you, Jill and Sarah.
Could you speak up, please, Phil?
Yeah, sorry. Thank you for that report. Obviously, not having sight of it, it's a bit tricky. I was wondering, you made brief mention of the psychological well-being of mothers in the earlier part of your presentation. I wonder if you could give me some details, but still relatively high level, about your safety plans for that and how you acknowledge and recognise any problems that you need to refer. And do you have any ongoing relationships, I don't know whether it's with talking therapists or anyone else, to help mothers that are suffering as a result of any postnatal mental health?
Yes, absolutely. Thank you. So antenatally, so when women are pregnant, we have some screening questions that we ask them at frequently during their pregnancy to assess their mental well-being. And we have a joint clinic which has been set up with one of our obstetric colleagues and the Perinatal Mental Health Service, so that where we do identify women that have particularly significant mental health issues or who potentially may develop significant mental health issues, they can be referred to the experts from both an obstetric and a perinatal mental health perspective during their pregnancy, so that a detailed plan of care can be put in place involving them as well. And that assessment, as I've already alluded to, continues during pregnancy and then in the postnatal period, where we have psychological care plans that we can put in place. And we have really good working relationships with our perinatal mental health service, and we can refer women to them at any point. And we also give women information how they can self-refer as well. And that's not to say we're cutting our GP colleagues out of the situation either, because we work very closely with our GP colleagues too, because often women that have sort of mild to moderate mental health issues, they're managed very effectively by GPs pre-pregnancy, and then they can continue to be during their pregnancy as well.
Okay, thank you. Yes, it's just that I'm aware that mental health issues can take particularly a new mother completely by surprise when they've never had any indication of any mental health before, and it's good to know that you've got some good pathways and links that are set up. Thank you. And actually, knowing as I do a few people from the Frimley end, I feel very, very confident that if they're giving you a certainly improved view of the service with regards to Cqc inspection and the potential way that that could be viewed, then that's good news. So well done.
Thank you.
Thank you. I know members in the chamber have questions for you. They've already been waving at me. So I'm going to start with Tahir.
Thank you for the presentation. That was really good. It'll be nice to get a copy of that. There were some parts of it which was quite small and I couldn't read it from where I am. So if you could pass that on. There was something that you said earlier on, and I remember, not trying to make any political points here or anything, but I was reading in the newspaper a few years ago that once Brexit started to cut in, there was a 96% reduction in people from Europe applying to become nurses and social care workers within the UK. And you said you were having success with recruitment internationally, and I was just wondering whether that was Europe, and if not, where is it? And if not, then are you having any success in Europe? Thank you.
Thank you. So the main success that we've had is recruiting from Africa, and we've had a number of really good midwives who've come to us from different countries in Africa. We're now working with an international recruitment agency to recruit from other areas of the world as well. There isn't a large number of midwives in Europe. So we're looking a little further afield. We're looking towards Dubai and that sort of area to see whether we can recruit from there. We have looked to, we did look in Spain and Portugal as well, because we have had some excellent midwives from those countries at the moment. But again, they're experiencing shortages of midwives, and so they're perhaps a little reluctant to lose them, which you can understand. So working with the agencies and working with the people who know a lot about international recruitment, and there are certain countries where you are allowed to go and actively recruit and certain countries where you're not. And so we're making sure that we're going to the most appropriate countries for the midwives who will be able to come and join us. And we have had a lot of interest as well as a lot of success.
Sorry, just to follow up, again, something I've been reading. And I'm not sure if I read this right, but did we get warned by World Health Authority from trying to get medical staff from other parts of the world? I think they warned us, or they warned the NHS to not be so aggressive. I don't know if you've heard that or not. It's something that recently I came across.
It's not something that I've read. We've just along the lines of international midwifery recruitment, we've actually had some. The Royal College of Obs and Gynae has an international recruitment programme called the Medical Training Initiative, and that's been a phenomenal success. You know, part of that the agreement is that doctors who've trained overseas, UK specialty training in obstetrics and gynecology is world recognised as providing extremely high standards of postgraduate training. So the arrangement has been that doctors can come over from overseas and benefit from UK-based training programs and help support our services in areas where there are particular recruitment challenges, medical recruitment challenges, with a view that they can then, you know, take those special, unique, high-quality training experiences and skills back home once they've completed their two-year placement with us. So it's the idea that of certainly with medical recruitment, medical training initiative, is that it's mutually beneficial, and certainly at the RBH we've had some really high quality and high caliber candidates, applicants and doctors come and join us and return home. So yeah.
Thank you. Thank you.
Jackie.
Yes, mine isn't a question. It's really a sort of congratulations, because I have my youngest daughter had her second child 8 years ago, and he died in the Royal Berkshire Hospital. There was fault there. So I was at the birth. It was a huge shock, but for her, it was traumatic. And in the end, we paid for her to have counselling because she was suffering. But so this birth reflection sounds absolutely fantastic, because they all have PTSD. You know, my daughter has post-traumatic stress. Every now and again, it comes back to her. So this is a real good step forward for any mother about the birth, a good birth or a death. Thank you.
Thank you, Jackie. I'm going to Councillor Michael Firmager now.
Yeah, thank you. Thank you, Chairman. It was a very interesting presentation, so thank you very much for that. I just got a bit of a correction to make, because on the Frimley visit, you actually stated on the presentation 30th of November 2022.
Oh dear, did I? Sorry.
Yeah, sorry. So it should be 2021. I kind of knew what you meant. So, I mean, February kind of fits in. So hopefully that'll be a good response. Yeah, to that. But one thing I was really quite interested in was the Me and My Baby app. I think that's quite a good idea. If it's useful information helps and so on and so forth. But really, as per the previous item, several of us were making comment that not everybody is on sort of online or IT or whatever they are. Is that available? The information there, is that available elsewhere as well? And if it is, where is it available? Thank you.
Thank you. Yes, it is. We have got written information as well, so we can print information out, and we have got it available in a range of languages too. So hopefully, all women will be able to access the information in a format that's appropriate for them.
Thank you.
Okay, Michael. Okay, Rachel. Is she behind you, Adrian? No. Okay, well, Adrian, would you like to go next?
Sorry, I'm a very large object. I'm sorry if I obscured the vision. Firstly, I'd like to say a huge thank you on behalf of the community for the services that you deliver, and there are many successes. In fact, you know, we had 3 successful successes 21, 19 and 17 years ago. Going back to a number of points being raised about where you're getting new staff. One thing that we've talked about a lot about is in specialist roles, trying to encourage British people, residents in the UK, into those roles. Do you think new or improved bursaries or something would help you in this area?
I think there's various routes and things that we need to look at. I think that for midwifery training, I think when they brought in some of the restrictions around the training, and particularly the financial restrictions, that did put some people off. So looking at different routes into that training, so whether it be through a midwifery degree apprenticeship route, or whether it be through there's some other sort of salary supports that can be put in place. I think that's the way forward, and we certainly have done a lot of work around using the apprenticeship to support staff to go into midwifery training with a degree of success, it has to be said, albeit we've only started it over the last 18 months. But I think that is a really good route into midwifery training. I think the other thing is that looking at the profession itself is making sure that when staff do enter the profession, that they have the development opportunities that they need to enable them to have the skills, the knowledge and the experience. And then they can choose which route they go into, whether they stay in clinical practice and they develop expertise in that route, whether they want to go into education, whether that be clinical education or through one of our universities, or into sort of more operational or the management side and the leadership of the service. And we're really fortunate that we have a really good programme of development opportunities for staff. And we do seek various funding opportunities to support that. And as I say, we are actually really fortunate that we are able to support that. And it is one of our the factors that when we are recruiting that attracts people to us.
And just to in parallel, from a medical perspective, training in obstetrics and gynecology is really tough and really challenging. The attrition rate for trainees in our specialty is about 30%. So 1 in 3 trainees who start learning their craft, will drop out, and that's something that we have to really think carefully about. So one of what we're trying to do is encourage more flexible working patterns, try and understand that people are trying to balance, sometimes balance family life or other pressures, to make training more appealing, encouraging people to take time out of training to pursue other interests, whether that's taking time out to do research, take time out to have a career break, or to take time out to go and gain experience overseas. That's certainly something that I did, and I think it's made me a better obstetrician for having gained that experience. And I'm very grateful for the people who gave me the opportunity to do that. But trying to understand, the challenges that our junior doctors face is a really important part of helping retain those good people, to train them up to be the consultants and leaders of our service of the future. So the challenges are not, I think the midwifery staffing sometimes hits the headlines and certainly captures a lot of attention, but the medical aspects are can sometimes be equally challenging, and we can learn a lot from the things that work well for midwifery staffing, and recruitment and retention in particular can also work well for the medical aspect. So yeah.
And I would like to support our chair, Alison, with a question as well around the KPIs. We are a KPI-driven kind of organisation, and we always want to get oversight of KPIs and obviously, you know, what action plans, actions are being driven out of those KPIs. So we would definitely have an interest in those areas. But one thing that interests me especially is customer feedback. Obviously, in terms of customer feedback, you know, the mothers and the partners, do you capture this information? Is this part of your KPIs, and does this do you follow through with some actions on that particular KPI?
Yes, we use the friends and family test. There's a particular maternity friends and family test. So women get the opportunity antenatally and then postnatally in hospital to feedback on their labour care and also the care on the postnatal ward, and then another opportunity in the home to fill out some information about their postnatal care. And as well as just rating, I think the most useful thing that we get is the qualitative feedback. Qualitative feedback, yeah. So again, we can look at any themes and trends that come out from that, and we do. And often we triangulate that against feedback we get from our Maternity Voices partnership. And also we have an annual national maternity survey, again, where it's usually women who deliver in February are all sent a questionnaire, and they're given the opportunity to fill, I say send a questionnaire, it's all electronic now, but they're given the opportunity to feedback around their experiences of our service. And we do use that to monitor progress against areas where perhaps we haven't done so well previously, but also to keep on top of areas that we need to maintain focus.
Another question. I see NHS England has dropped the limit of 20% of Cesarean births because of the what was going on at Telford and Shropshire, I believe. Does this have any impact whatsoever on RBH, and where was RBH in relation to that 20% limit?
Our Cesarean section rates have been what were they on the last dashboard, in this sort of 30% overall. So we've noticed, yeah, we've certainly noticed an upward trend, and we've been looking very closely at that. I think we all welcome the sort of move away from an arbitrary target, because really a number is not terribly helpful. There are lots and lots of factors that influence women's choices about influence women's choices about how they deliver, but also lots of factors that can influence decisions around Cesarean section rates. So I think removing it and making it a little bit more you know, taking away those rigid parameters, I think is only a good thing, and will stop us beating ourselves up over chasing an arbitrary target.
That's really encouraging. I was also very encouraged actually to see that IT integration is kind of working, merging 3 systems to one. When we were frequent flyers, there was lots of huge piles of paperwork everywhere, I remember. And it's also very encouraging, I see, and Phil's already mentioned this, the peer review with Frimley, and I would say the sharing of best practice across organisations, I think is really to be applauded, and very encouraging. You know, 20 years ago when our children were being born, the maternity block was struggling a bit from concrete cancer and these kinds of things. And there's 1 or 2 comments in the report around the physical buildings. Last question is, does Nikki have a very large cheque in her back pocket to give you a new building?
Nikki, over to you. The estates issues are myriad and challenging, and yeah, don't think I have an answer to that.
So you'll be aware, colleagues, that we were selected to be in the HIP2, the New Hospitals programme, recognising the state of our overall estate. We've got vintages of every decade and most centuries actually on site, and we continue to deal with some of the issues that come from that mixed architecture every day. I think it's fair to say that parts of the estate are probably past their estimated original useful life. We have an extensive backlog maintenance programme that we're addressing. Indeed, the year before last, we delivered a 34 million capital programme. Last year was 64 million. And it's a little bit like the Forth Bridge. We're constantly maintaining. You'll be aware that one of the big improvements we've made in the last 12 months, actually, which has affected all of our buildings in a positive way and the environment in a positive way, we've de-steamed the site. So maternity block, like many of our other blocks, was subject to the vagaries of our very old steam conveyance system, which has about 3 kilometres of leaky steam pipe was running underground, so made it very difficult to do maintenance and to guarantee hot water temperatures and heating standards. So in the last year, we've replaced the steam underground heating system with hydrogen-ready new boilers. We're already saving millions of gallons of water each year, and each building now has much more controllable central heating within it. And the maternity block as well, in terms of temperature control, we've also replaced all the chillers in the maternity block. Again, recognising colleagues wearing full PPE, including the FFP3 masks, to make sure that we had comfortable temperatures in which to work, even in the heat in the summer as well as the cold in the winter. We're continuing to upgrade the maternity block where we can and make some retrofit changes, and we welcome feedback, as Sarah and Jill will know, in terms of working with those who are using the building to see what else we can do to improve it. I think it's fair to say we sometimes look enviously at brand new facilities and think, oh, I wish we had that, but we're working well. We've submitted our strategic outline case to our regional finance teams and for Treasury consideration, and we're now heavily on our journey towards the outline business case, which is the next stage of our hospital redevelopment, and hoping to get clarity about the funding envelope that we will have, which will determine which of the options we've considered thus far, whether that's a total site redevelopment, as in a greenfield brownfield site, or whether it's a phased and more partial redevelopment of the existing facility. But certainly we've avidly gone after any additional capital that's been available, including the purchase of additional medical equipment to help. And we've been very successful this year in terms of securing additional diagnostic imaging equipment, which again, ultrasounds have helped benefit the maternity services that we offer. So I think it would be fair to say there's more to do, and we've already done a lot this year, but we're striving all the time to make the physical environment as good as it possibly can be, and we're really, really glad of the support of the staff that have been working with us through, I say November, the new maternity system implementation. Even though we were mid-pandemic, we had to hold our nerve and go for it, and I think that's really enhanced the physical environment, as well as you observed, colleague, about the number of paper files we used to have everywhere. It now means wherever a woman is in our system, we've got access, or our colleagues have got access to her records without having to go on a hunt to see where that folder might be located if she'd had to move quickly from different areas around the organisation. So yeah, we've got more to do, and we've done a lot in the last 12 months, but just say again, I'd just like to go on record to thank colleagues who, it's not as though we can close the department while we make these changes. We have to be open and available for business 24/7. So it's a huge team effort. Thank you.
I sincerely hope you get a massive envelope, but thank you very much for your presentation.
Okay, Rachel.
Hi. You've actually addressed part of the answer to my question already, but I was wondering, what are the biggest barriers for you in getting enough staff, and to what extent these are national problems and to what extent they're local problems?
Well, I'm sure it won't be a surprise to know that there is a national shortage of midwives. I think that's been well covered in the media lately, which is why we're looking to focus on international recruitment at the moment. And that's also why we're increasing the number of clinical placements for student midwives. And although that's because the training is 3 years, we know that that's going to be a little bit down the line, but if we plan now, then hopefully we'll have the long-term benefits of that. It's not that the money isn't there, because we have got funding for midwives, and there has been additional funding that has been made available from the national team as a result of the focus that's been on maternity services recently. It is really, as I say, the issue of the number of staff who are available to take up posts, and that's why we're working with our colleagues on international recruitment.
Super, thank you very much.
Thank you.
Okay, and finally, I think Sam.
Thank you, Chair. And a great presentation, guys. Really, really interesting to learn about the great work. I myself was born in the ward, so that was either a success or an unsuccess, depending on who you speak to. But yeah, I just really wanted to understand around the UNICEF baby friendly accreditation. Really great. Start to learn a bit more about what that involves. What would you need to do to get the accreditation, and what benefits once receiving it?
Thank you. Yes, it's quite a complex process. So there are various standards within it. There's 10 standards, and some of them relate to having the right policies and processes in place. Some of them are around the training, so the level of training, the frequency of the training. Some around the assessments that we do for staff. And the main part really is around making sure that women are given the right information at the right time and the right support that they need to make informed choices around infant feeding. So as I say, there's 10 standards, and what we're doing is we've re-benchmarked ourselves against the standards and know the areas that we've got to focus on. So some of that's around doing some more work antenatally with women. So when women are pregnant, talking to them about infant feeding and the options that are available to them, and also the support that's available as well. So we start antenatally, and then we then support women with making sure that they're given the choice for feeding their baby in the very early postnatal period, so whilst they're still in the birthing rooms. So we will support them either to breastfeed if that's their choice, or if they choose to use formula feed, then we will support them with that as well. And then obviously that then goes into the postnatal period. So again, we need to work with our staff on the ward. So that's not just the midwives, but the support staff and everybody else that has contact with mums and can offer them support. And then make sure that the care plans that are put in place then follow through to the community. And we've got an excellent team of support workers who work in the community, who can also offer ongoing support for infant feeding, as well as the midwives. And then making sure that we communicate well with our health visiting colleagues, so that those plans then move over to our health visitors when they take over care as well. So with regards to the actual accreditation, we have to be able to provide the evidence that we're achieving all 10 standards. And to do that, some of that is just documents to make sure we've got policies and processes in place, that we've got training needs analysis completed, that we've got training documents, and that we can evidence that staff have the annual assessments that they require. The biggest part is the assessors will actually come and talk to the women on the postnatal wards, but also they will contact women who have used our services, but maybe 2 or 3 weeks later, and just talk to them about the support that they had both antenatally, immediately postnatally, and then both in the hospital and at home postnatally. to see that they were given the right information, the right support that they needed. And then once you pass all of those, then they will accredit you as being a baby-friendly institution.
Brilliant. Thank you so much.
Thank you. Sorry, there wasn't a quicker answer.
Okay, thank you very much. I think everybody here really values the work you're doing. We know that you're working very, very hard and that you're always putting every mother, you know, as an individual and treating her, you know, the best way. You know, meeting CQC targets is not at the forefront of your mind. You know, my children also were born there, and I'm not sure how long you've been there, Jill, but I've got a feeling you might have been involved in the care of one of my children. So,
I've been there 39 years, so quite possibly.
yes, I did think I had met you. So thank you very much. And thank you also to Nikki for joining us. Nikki, I'm sure we'll see you again because we are keen to hear more about plans for the rebuild and relocation. So thank you very much. Please do feel free to leave the meeting at this point.
Thanks for having us.
Thank you.
Thank you very much, Chair, for having us. Thank you.
I think we're going to be able to email the slides to all of you following the meeting. All right, the next item on the agenda, we're welcoming Martin Sloan. Martin is our Assistant Director for Adult Social Care Transformation and Integration here at the Borough Council. Who's going to be giving us a presentation on health integration, which is on page 19.
Okay, thank you. And
hello, Martin.
Yeah, thanks for inviting me. And obviously, I'm here. Lewis was meant to come here, but he couldn't make it tonight, so I'm filling in for him. So I was just going to share my screen and just run through the slides to give you an update. Are they on the screen? Yeah, and basically just want to sort of say,
okay. Can we make that full screen, please?
Is that better? Hello?
We've still got your sidebar.
All right, so it's all right. Sorry, yeah. That better?
That is. Thank you.
Okay. All right, just get the size. Yeah, okay. I just really just wanted to make a couple of comments because obviously we have come previously to HOSC to update on the partnership working, and Wokingham Integrated Partnership is one of the partnerships that feeds through to Wokingham Wellbeing Board, and the Wokingham Wellbeing Board has recently basically signed off a new wellbeing strategy, so that obviously influences a lot of our work. And you'll see from the diagram all the sort of partners that are involved in our partnership, and we tend to focus more on adult services. There is a separate children's partnership in place that obviously focuses on the younger age group. And just want to make a couple of observations since the last time we were at HOSC. In the primary care networks, we now have 5 PCNs, so there's an additional one has started over the last number of months. And also, we always had one representative from the voluntary sector, and it was through Involve VCS, and now we've actually expanded that to 2. So we have the chief officer from Wokingham Volunteer Centre also sits on our Wokingham Integrated Partnership. So we just expanded that because of how much work we're trying to do with the voluntary sector. And you know, Wokingham is very fortunate to have a very vibrant voluntary sector, and it's about how we try to maximise the benefit of that for our residents. So if we just move on then, in terms of the overview then, basically each year the Integrated Partnership agrees a work programme for the next year, and we do that sort of in sort of March, April time. And obviously then we submit that plan to NHS England because it's all part of the Better Care Fund that is coordinated through the NHS. So we submit that plan for approval. So this current year, we basically had, these are our key priority areas, which I'll go through. So we've focused on mental health and social inclusion, deconditioning, rehab, physical activity, frailty monitoring, inequality and poverty, and probably poverty has been picked up through the council's separate anti-poverty strategy. So that's really where that has been picked up rather than through our integration board. Social prescribing, which I'll come back to, and then we have to do certain monitoring around the Better Care Fund because there's quite a bit of funding involved and there's national targets, and we have to basically do a lot of performance tracking and KPIs to see how we're doing against those. And this has led sort of to basically 19 projects, and you know, we've worked really hard this year. It has been mentioned in previous presentations there. We've had the impact of COVID, you know what I mean, and that has had a significant issue in terms of both on, you know, staffing levels and absence, also certain facilities, and we couldn't run certain functions, you know, at different times during the year, and also just the public staying inside and not not being able to go out. And first of all, in terms of those that were asked to shield, and then more lately, quite still a number of our residents are quite scared to actually come out, and that's obviously leading to more social isolation and mental health issues. So you know, COVID has had a huge impact and will continue to have a huge impact. And I know the minister announced various relaxations today, but COVID will, you know, the impact of COVID will be with us for quite a while and will feed into our programme, you know, both currently this year and into next year's programme. So in terms of just looking then at what we have done, so this really is, we do this review each year. We do it around sort of December, January time, where the integration board looks at all of our schemes, where we're spending funding, what we've achieved, and then out of that we decide whether we keep going with schemes, or in the past we have closed certain schemes and then redirected that funding to other priorities. So that's, you know, it's an ongoing annual process where we try to make sure that we're getting the best return for the money that's in this area. So in terms of mental health and social inclusion, then really it's sort of been two big and key areas that we've focused on, and this has been massive both before COVID and equally then COVID has exaggerated that significantly. So we've implemented a MIND service, which is sort of the low-level mental health service. So those that don't meet the criteria for the statutory, you know, services that mostly BHFT provide. And that has been set up and has been working all year and has been a real bonus for our residents. So that now is in place, fully working. They're nearly at capacity. It does, you know, when you implement a new service, just implementing the service and recruiting the staff is one thing, but then getting it integrated into the system and making sure that everybody knows about the service and making referrals, that does take time. So at the minute, they're getting close to capacity, but there still is room for further referrals. And one of the other things that the MIND service does is also it set up a mental health alliance, so it brings in other voluntary sector organisations, because part of our sort of specification for this service was that we actually tried to train up all of the voluntary sector to be more aware of mental health issues, so they then can deal with certain things, and then they can also refer into MIND. So you can see from the thing, we basically supported probably over 250 clients, and we use a wellbeing score, the Warwick Edinburgh Mental Wellbeing Scale. So we actually then do a sort of whenever the person is referred, we do a score, and then at the end of the service we do another score, and that has shown us that we are, you know, significantly improving people's well-being by going to the MIND service. So that's been a really positive success during this year. The other key area that we have worked through, and this is probably in the second year of it, because last year we had the Friendship Alliance Phase 1, and then this year we put additional funding into the Friendship Alliance. And oh, sorry. Something's happened to my computer. Can you still hear me?
Yes, we can. We can see you, but we don't have your screen
sorry.
anymore.
Yeah. Okay. Apollo. I don't know what my computer is playing up.
Okay, Madeline's sharing the screen again now. We can go, that's great. Thank you. Continue.
Sorry, I can't see anything. This is good. Right. Sorry. Apologies. I can see now, Madeline's. Apologies about that. Okay. Yeah, so Friendship Alliance is really, we've got 4 sort of key voluntary sector organisations involved in that, which is basically Involve, Age UK, the Link Visiting Scheme, and Wokingham Volunteer Centre. So they are sort of the 4 key partners, and they basically have come together to work on trying to help mostly social isolation and help people get out of their homes, make friends, and really make a big difference. So we've had a number of different things funded through Friendship Month, where we had over 300 residents attended about 30 odd events. We had friendship cafes. We expanded the Age UK information advice, and there's probably about 600 odd people additionally getting information advice through Age UK. We have implemented a Link Express, which is a befriending scheme where we try to quickly, responsibly respond to somebody who is in isolation, give them a short, quick service, and then pass them and join them up then with a befriender that suits their needs. So that has all been really positive. And also we had a digital inclusion project as well, where you can see we helped over 45 older people to actually then have tablets that they then could get in touch with their wider family and friends. So all of that has been a really huge success and really needed, and has been massively influenced by COVID. Next slide then, Madeline. Then in terms of deconditioning, then this has been a key area for us over a number of years in our integration board. And it's really, the whole idea of keeping people independent and providing sort of responsive reablement services has been key over a period of time. And at the minute, there is a new programme that's been funded through the NHS called Ageing Well. And we're sort of tying in with that because they've got a 2-day target for reablement to try, and they've got to focus now on trying to improve getting people rapid access to reablement to then keep them independent and in their own homes. So it avoids hospital admissions, it avoids deterioration, and therefore needing more statutory services. And one of the things we've just recently completed, we did an exercise looking at it, it's called the Surrey Model. And this is really, rather than having a dedicated service for reablement and then having all of our domiciliary care provision, which from providers that basically just do onto people, we're looking to see whether we could actually train up our dom care providers to have a more reablement focus. So all of our domiciliary care has a reablement focus, because we think that actually could be a better model. So that's something that we've piloted. It was working well, and we're going to look at that as part, as maybe one of our projects for next year. And that's been really positive. The other area I wanted to mention then was moving with confidence. And again, this has actually been working with our voluntary sector and our sport and leisure staff in the council. And what we've done is our sport and leisure staff, we provided additional staff, and then they actually went into people's homes. So these were people who, because of COVID, hadn't been out of their house for months, and they deconditioned, and they actually lost the ability to actually, to get up, walk, and go outside. So we've actually been providing one-to-one service in people's own houses to actually go in and do one-to-one, basically coaching to get them out of their seat and active, and then getting them to actually go outside and then join other events. So that again has been a really positive, and it's interesting that we just recently won an award at the Get Berkshire Active Award. So we got a Physical Activity Hero Award for that service. So that was a really positive, and is still running and still is needed, because there's still quite a few people that aren't keen to go out of their homes at the minute. If you go on to the next slide. Sorry, that's the other way. You've gone back one. Okay, then other schemes that we've done under this sort of area of deconditioning is the leg ulcer pilot, and this is really sort of working with BHFT, Berkshire Health Community Foundation Trust. And what they have done is done a renovation of their facility and basically set up a group clinics for this leg ulcer pilot. So the soft launch in November, it's just launched at the end of January. And, you know, it's obviously very early days for this project. It's taken a good while to get up and going, but, you know, initial feedback has been really positive, but we'll feed back in due course on this project. But that again is a very welcome development. Also, we have been focusing on the Oak Wing, which is a number of beds to try and help get people out of hospital quickly. So as soon as somebody is fit for discharge, sometimes they can't go directly home, but they don't need to go into a residential or a care home. And what we do then is we bring them out into Oak Wing for a number of weeks, do bereavement and support, and then from there then we can make decisions in terms of what's their ongoing care needs. So it really is a way of trying to quickly get people out of hospital, and then D2A is discharged to assess. So you actually then do the assessment, not while they're in a hospital bed, which isn't really a sensible environment to assess their ongoing needs. You bring them out into the Oak Wing, which is a number of beds, and then we basically assess them and then meet their needs after that. The other area where we're using some beds is in Wokingham Hospital. And again, basically the way this has worked is people, you know, if somebody is in need of care, they go to ED, they get their tests, and mostly at RBH. And then instead of then needing to go into an acute bed and use an acute bed, they're discharged back to Wokingham Hospital as a sort of like a step down facility. So because they don't need actual acute care, and therefore that then is a much more cost effective and safe way of managing those patients without clogging up the RBH. So again, that's been a very positive project. On to the next slide. Then around frailty monitoring, a couple of things that we've been trying to do, and this is probably hasn't gone as quickly as we could have. We have multidisciplinary team meetings, and what we were wanting to do was to recruit additional social workers in adult social care in the council, and then assign them to each of our primary care networks. So therefore the GPs would have then a named social work person. And then what we would do then, we do proactive work to then target, you know, certain individuals on the GP list to then actually then agree work plans and see how we can support them before they hit a crisis. So we have just managed to recruit the extra staff, so that really will get up and going, but it was planned to have been in place before, but we've had recruitment challenges, but we've now got them in place. So again, that will we can feed back on that at a future meeting. The other thing that we've done then is we've recruited PHM is Population Health Management, and what we've done is recruited a new post into our public health department in the council. And this new post then is basically trying to look at the data. And I know we've mentioned earlier presentations around, you know, better IT systems. And this here, this person then, role is to try and create like a primary care network profile and try and actually target actual work plans to address certain individual needs. And one example that we've done over the last while is we've had a lot of Hong Kong people have come and become resident in Wokingham, and we did a webinar trying to explain how our health service and health and social care works, and that has been really positively received. So again, that's one of the roles that this person is doing, is trying to actually look at our data and make us become more evidence-based so that we can focus on inequalities and use the data. Next slide. Around social prescribing, and you may be aware that each of the primary care networks, they're obviously expanding their team in general. So it's not just a GP in the practice. They have they can have a pharmacy, they can have physician associates, and the other post that they have all been recruiting to is a social prescriber post. And what we've been trying to do is a lot of work in terms of saying how can we actually help them. And we've been piloting this Project Joy, which is an IT solution, which makes it really easy to refer people on. So you can go on and see what services are available, and then you can do a really easy referral onwards to that mostly voluntary sector organisation. And again, then the system's built in, so then it follows up to make sure it has the person attended, and we can see that we're getting 78% attendance rate. So when somebody is referred on, they're actually going ahead and having that follow up with the other organisation. So Project Joy is, we think there's a lot of benefit we can get from this. So, and we're just at the minute out, we're just about to go out to recruit, to basically procure the system properly. We've obviously been funding it as a pilot over the last 12 months. So we're in a procurement phase now to actually get it in place on a permanent basis. Connected care review, and this is something that we're just involved in. This runs right across sort of Berkshire, okay? And this is really about trying to have like a joint health and care record. So it's pulling information from, the acute sites, so RBH, it pulls records from them, pulls data from primary care, from community trusts, from social care, and therefore enables people then to see the person's record. Obviously, it's all done in a way that you only see what you're allowed to see, but it really does improve then the care, because you actually can then see the actual record and the full record of the person. So that has been a big success, probably more so in the acute, and in health than in social care. But where we're seeing it really benefit us is our population health management analyst has got access to it. So in terms of doing health inequality profiles, we see that this is a huge value in us actually using this data to actually target some of our proactive work. So again, that's really just starting at the minute, and we'll be able to feed back more at the following meeting. Next. Then a couple of areas where we haven't, as I said at the start, COVID has an impact, and there's a couple of areas here that we're on our work program and we just haven't got to them yet. So creating healthy communities, how we try and engage in each PCN with the local community to try and agree what our plans are and how to maximise that sort of community response. So we are running our first community workshop in one of our PCNs in early March, but we had hoped to do one in each of our PCN areas, but that has not happened. So they will be planned going forward, but COVID obviously massively impacted on trying to run events. And equally, our service user experience, while we do get feedback from our service users, it's an area that we want to improve on. So we did do a business case to try and see if we could do something with our other local authority, our integration boards in terms of Reading and West Berkshire, but we just weren't able to get that agreed on time. So this is still work in progress, and we will improve our service user experience and then obviously use that to feed back to the likes of your meeting in terms of what we're getting back from users. And then the social prescribing, then one of the things that we're doing to try and help right across all the PCNs is we've agreed with Involve that they run a forum to try and get all the social prescribers from all of our 5 PCNs together. So we then actually try and learn and work together. So we actually maximise the benefit, because they're all sort of individuals, and it's very difficult then for an individual to work on their own. So we do a lot of sort of joint training across the social prescribing to maximise that benefit. Next slide. And then the virtual groups then, we've probably had about 600 individuals have joined groups, and these have both been led by RBH and by our PCN clinical directors. And this is very just much them targeting individuals, running online sessions, and one of them was around long COVID. And again, that has been excellent. And I appreciate not everyone has online access, so it's not the answer for everything, but it has made a significant improvement and benefit to a lot of people during this year. Next slide. And then this is just the final slide then, just around the Better Care Fund, because we do get national funding and there are national targets that we have to report in on. So we obviously submit our plans, we do a dashboard, and we submit back to NHS England. And just in general, you know, against the key targets we're measured against, our performance is the best across sort of Berkshire West. All our targets are better than the national average, and the targets that we're mostly measured on is around avoidable admission. It's trying to keep people out of hospital, so it means it doesn't clog up the hospital, making sure that people don't stay in hospital when they are in there more than 14 or 21 days, and also trying to make sure that when people do come out of an illness or whatever, that we don't put them into care homes. You know, that's the last choice. We try to get people home into their own homes and keep them independent with the right support. So we then, you know, we make sure that the care homes aren't filled with people that don't need to be there, because everybody wants to stay at home as much as possible. So that is really just a summary of the integration performance over the first period of this year. Happy to take questions.
Thank you very much for that, Martin. Absolutely packed full of good news. Clearly, everybody at the Borough Council has been working with our partners very hard. Some really inspirational, great ideas that you've put into action and come through. The only thing I did want to ask, but I didn't quite understand why often the word success had BAU in brackets.
Sorry.
Well, yeah, I understand business as usual, but they were often sort of big changes, and you know, so the success wasn't that we were back to business as usual post-COVID or things were normal. You know, you achieved something brilliant. So I just didn't quite follow that.
No, that's okay, and apologies. It's just some of our abbreviations. But no, what it means is that project now stops being a project, and we just continue it as part of our normal work. So it means next year's programme, that will come off the programme because it's no longer a new project to deliver. It's been delivered, and we're continuing to fund it recurringly, and therefore becomes just part of our core service. And that's what we call sort of business as usual. So it means therefore that will continue on as a normal service as part of our you know, range of services that we've got.
Yeah, I mean, we did have quite a lot of abbreviations in this, but I think you pretty much explained all of them as you took us through it. Right, let's have a look. Members, we'll start with Rachel, go to Michael, then Sam. I'm sure Adrian will thought one soon. Okay, Rachel.
That was a very interesting presentation, lots of information in there. Thank you very much. I'm really interested in the work that you've been doing about inequality and the poverty analysis and reporting. And I'm wondering what's emerging out of the analysis that you're doing on that, and where you're looking to take that in the future.
We're really getting into this, and we're starting it. So, and one of the key areas is cardiovascular disease is a key area that we're trying to focus on. But what we're actually planning to do is to do like a population profile for each of our primary care networks. So each of our networks then will have what are the priorities for their patient list size. So the plan is that we will have that completed over the next sort of probably 2-3 months. And then out of that then will come a work program then to try and target that priority in that PCN area. So that is the sort of plan going forward. So it's probably early days where we're trying to use the data, and back to that sort of connected care that I was talking about. So we now have access to a lot more data, and it's then converting that data into what's the evidence and using it then to actually inform what our program should be, and then moving away from reactive services where we wait till somebody is sick or wait till somebody's in crises before we help them, to then actually trying to target people and do proactive, more prevention work. So that's our plan. It still is early days, and happy to come back and sort of outline key examples of what we're going to be doing in future.
Yes, that would be brilliant. And I was going to actually ask if there is a councillor who's particularly interested in that work, and I'm putting my hands up there, whether I might be able to get hold of summaries of the non-confidential information to familiarise myself with it.
do that.
Brilliant. Thank you very much indeed.
Okay, thank you. Sam. Okay, Michael.
Thank you. Thanks, Sam. Yeah, thank you, Chairman. Yeah, thank you, Martin. Very interesting, very positive looking report there. Just one bit I would, and it's kind of on the IT bit, which is kind of what I really centre into probably every single time. But the virtual group clinics has obviously had a very, very good feedback, and people seem to like the experience of it, and obviously got a lot out of it. I mean, you sort of said that it's obviously geared to IT. I mean, are you going to do something that's non-IT for the people who aren't on the internet? And if you are, what would that be? Thank you.
Yeah, mostly this has been, our health colleagues doing this. So, for example, the GPs, they have done a lot of virtual clinics, and obviously, for those people who don't have access to that, then what they're doing then is actually inviting them into the practice. You know what I mean? So they're obviously we're aware that not everyone has access, but so it works really well for those that do. And then what they're having to do then is more face-to-face for those that don't. And I think that's the only option that there is for that cohort. And we do know that there's still a reasonable number of people that don't have access to online. And partly you can see why what we're doing in our Friendship Alliance, we are actively trying to get more, frail older people to get online access, you know what I mean? So we're sort of trying to do it both, target both ways, but it will still take some time till we have full rollout, and probably may never get that.
Yeah, thank you for that. I mean, I think with the COVID, one of the probably the biggest response that people wanted, certainly with GPs, was to go to face-to-face rather than having online or phone appointments. No, we've all experienced that, and it's absolutely a complete pain. So anything that gets back to a face-to-face, if people want it, of course. If they don't, if they're happy with online or phone or whatever, it obviously depends what their sort of condition is, I guess. But I would certainly applaud, face-to-face, because that's the best way you can do it.
And I think the NHS has set out targets for primary care to get back to a certain percentage of face-to-face. So there is a clear direction that the government does want to have more face-to-face than obviously was happening during COVID. So it is returning to that. But I do think for quite a number of people, online or whatever is a very efficient and effective way. So I think there will be that mix, but it needs to have that mix available.
I mean, certainly needs to respond to what the patients want. But yeah. But thank you for that, Martin.
Yeah, I have to quote your report. In your report, you say over 45 elderly people. I know I'm in trouble now. When's my pension coming? I didn't realise that was a sort of category. I think it's just a bit of a misinterpretation of what you're trying to say there. It's not the age, it's the number of units given to people. Is that correct?
Sorry, you're right. Sorry, 45 was the numbers as opposed to the age. So apologies if that came. No, yeah, absolutely. And
I think other councillors have mentioned this, but it's a very encouraging report. And I think Matt Pope has been talking about this kind of vision for quite a long time, which is also, I would say, very encouraging. It's great to see individual projects get up and running and be successful and be converted into BAU. It's also great to see you working with other larger organisations to make sure that you integrate where appropriate into other larger organisations. But the thing that I really miss here is any sort of costings. There's no financial numbers anywhere in here. And I think it would be good to give an indication on project costs. One thing also, because this for me is service transformation. So the question is, do these project costs go through to the medium-term financial plan as transformation costs?
we do have all the costs, and they're fed back into the integration board. So we have that information, and we can share that in future at this board. The funding for this is all separate to the medium-term financial plan. So this is all basically a separate funding that comes through. So therefore, it's not included in our medium-term financial plan. The council obviously works alongside this, and obviously through adult social care puts some bids into the medium-term financial plan, and some of that goes towards voluntary sector transformation that then feeds into the integration board. So there's a bit of indirect link to the medium-term financial plan, but mostly we get additional funding through NHS into Better Care Fund, and then that's the new monies that then we're spending on some of these new schemes.
I mean, next time you present, I think we would all request that you come back and present again. I think it's been a very useful session, but I would like to see some numbers. Thank you.
Yeah.
Right. We'll go back to Sam now.
Thank you, Chair. Great presentation again, Martin. Thought it was really insightful. Great work you guys are all doing. My question was in relation to the Friendship Alliance. Really interested in the area. I think I've previously volunteered for the Link Visiting Scheme, which you mentioned. I know they're a great initiative. Question was regards to Friendship Month. You think you said you had 300 residents get involved with that, so that sounds really great, and you had a lot of success with Friendship Month. Were there any learns from that which maybe next time around you would do differently? And are there plans to potentially roll this out again, or was this like a one-off?
What we've been trying to do around the sort of voluntary sector is to put funding in recurringly. So it means therefore, because the voluntary sector have always over the years got non-recurring money, they do work and then they can't sustain it. So what we've really worked hard at through the integration board and also some of the council's own adult social care funding is that we try to do things that if they work, we then fund them recurringly, and therefore they can continue to do that. So, the Friendship Alliance, the Better Care Fund has probably put in about £200,000 worth of funding into these schemes, to fund, additional permanent staff. And obviously then, as you're saying there in the link, they have massively expanded their number of volunteers. So it's really good value for money. So the intention is that we can continue to do this. So the Friendship Month is something that obviously it was originally going to be a Friendship Week, and then we decided to go for the month, and we ran over 30 odd events. So it's that sort of thing where you were constantly trying to expand and have more friendship cafes and more services. So it means therefore the people of Wokingham can get out and about, and COVID has had a massive impact, and I don't think many people really understand just how much COVID has impacted on our resident population. So the more that we can do with the likes of the Link and Age UK and other our voluntary sector organisations, the more. So our intention is to keep going at this, and therefore all of these things will become, as I say, business as usual, and therefore they're just part of the service that our residents can get access to. So, the intention is that we keep expanding on this and doing more rather than less.
Thanks, Martin.
Okay, Martin, I just wanted to ask you, with the advent of Bob, will we still, have full control on where the funds from the Better Care Fund will be spent?
Hopefully. Bob, but obviously Bob, which is Buckingham, Oxfordshire and Berkshire. So the way that the health services is sort of being organised, we're losing our sort of local clinical commissioning group. So they're all going into Bob, which is challenging for Wokingham to try to keep our focus on Wokingham issues and so on like that. So at the minute we're being told that the integration board is continuing and we will still have control over the Better Care Fund. But I do think it's something that we have to, fight hard to continue to have that. And I know, Phil and others are involved in that. And I know Matt and Susan are involved in the ICS debate and structure. So it is a risk. At the minute, we do really good work through our integration board, and it does work. And I think people recognise it works. So we're trying to push hard to say that Wokingham should continue as a place-based partnership and get formally recognised as that. We still have a bit of work to do to get that all finalised and in place, but it's something that we just need to keep an eye on and all work really hard to keep Wokingham as an entity, because I think we've shown how by doing things locally and we do make a difference. Do you mean? And our residents get a benefit from that, and it would be a big loss if we moved away from a Wokingham integration partnership. So it's a risk, and over the next probably 6 months we'll get a better sense of exactly where it all settles down. But the NHS does have a tendency to try to move things to a bigger scale and therefore not have things local. So we do need to push hard to keep it local.
So do you feel that in comparison to neighbouring councils, our integration board, has achieved some incredible things? It is quite exceptional.
I think when you look at our performance and all the work we've done, I think we probably are one of the best performing integration boards. Do you mean? And I think some of our work, we're one of the top right across the UK. I really think that some of our work is exceptional. So, yes, I think we're in a really strong place, and we've worked hard, like probably the last 4 or 5 years, we've worked really hard to build that trust with our partners, because, that's really what makes the difference. And at the minute, we've got really good partnership working, and especially with our primary care colleagues. And primary care is it's a big area, and we want to try and help and support primary care access and all that. So it would be a real shame if we weren't able to continue all of that. There is a bit of a risk, but I think we're in a good place to argue for it to continue, and I think we can do that strongly.
Well, I think everybody here, we're all very proud of you. We think you've done a fantastic job. You and the team, obviously, Martin. We know you didn't do it single-handedly. We didn't become the healthiest borough in the country. It wasn't a lucky thing. It wasn't just because of who lives here. It's because of the work that we constantly do to support our residents, to enable them to have, healthy, active lives. So thank you very, very much for everything you're doing. Adrian, Rachel? Just having a chat. Right, so members, if we've got no other questions, I'll say thank you very much to Martin, and thank you members for attending tonight, and I'll close the meeting.